In this video, I'm going to be going through carpal tunnel syndrome. Carpal tunnel syndrome is caused by compression of the median nerve as it travels through the carpal tunnel in the wrist, causing pain and numbness in the median nerve distribution on the hand. Let's start with some basic anatomy and pathophysiology. The flexor retinaculum is a fibrous band that wraps across the front or the palmar side of the wrist. It's also known as the transverse carpal ligament. Between the carpal bones and the flexor retinaculum, there is a passageway from the forearm to the hand which is called the carpal tunnel. The median nerve and the flexor tendons of the forearm travel through the carpal tunnel. Compression of the contents of the carpal tunnel, causing carpal tunnel syndrome, is the result of either swelling of the contents, for example, swelling of the tendon sheaths due to repetitive strain, or narrowing of the tunnel. The branch of the median nerve that passes through the carpal tunnel is called the palmar digital cutaneous branch, and is responsible for sensory innervation of the palmar aspects and the full fingertips of the thumb, index and middle finger, and the lateral half of the ring finger. It's worth noting that the palmar cutaneous branch of the median nerve provides sensation to the palm. However, this branch originates before the carpal tunnel and it doesn't travel through the carpal tunnel. Therefore, it's not affected by carpal tunnel syndrome. The median nerve also supplies the motor function to the three thenar muscles. These three thenar muscles make up the muscular bulge at the base of the thumb that's responsible for thumb movements. The abductor pollicis brevis causes thumb abduction, the opponens brevis causes thumb opposition, and thumb opposition is where the thumb reaches across the palm of the hand to touch the tips of the fingers, and the flexor pollicis brevis, which is responsible for thumb flexion. The other muscle that controls thumb movement is the adductor pollicis, which causes thumb adduction. This muscle is innervated by the ulnar nerve. Whether it's classed as one of the thenar muscles depends on where you look. Let's talk about the risk factors. In most cases, carpal tunnel syndrome is idiopathic, meaning there's no clear cause that can be found. There are a number of key risk factors, including repetitive strain, obesity, being perimenopause, rheumatoid arthritis, diabetes, acromegaly, and hypothyroidism. A tom tip for you: when I was preparing for the PACES exam, the link between bilateral carpal tunnel syndrome and acromegaly came up several times. Cases would present a patient with symptoms of bilateral carpal tunnel syndrome. The challenge was not only to diagnose carpal tunnel syndrome, but also to identify the underlying cause. Whenever you see a patient in an OSCE station that has a diagnosis, ask yourself whether that diagnosis might have an underlying cause and look for the features of that cause. For example, if you see a patient with bilateral carpal tunnel syndrome, look for features that might suggest underlying rheumatoid arthritis, diabetes, acromegaly, or hypothyroidism. Going this extra step will take you from average exam scores to the very top scores. Let's talk about the presentation. Carpal tunnel syndrome usually has a gradual onset of symptoms. Initially, the symptoms are intermittent. Often they're worse at night time. Carpal tunnel syndrome causes sensory symptoms in the distribution of the palmar digital cutaneous branch of the median nerve, affecting the palmar aspects and the full fingertips of the thumb, index and middle finger, and the lateral half of the ring finger. Sensory symptoms include numbness, paresthesia, which is pins and needles or tingling, a burning sensation, or pain. Patients often find the sensory symptoms are worse at night time. The symptoms may cause them to wake up from sleep, and they may describe shaking their hand to try and relieve the symptoms. The motor symptoms of carpal tunnel syndrome affect the thenar muscles at the base of the thumb, with weakness of thumb movements, weakness of grip strength, difficulty with fine movements involving the thumb, and wasting of the thenar muscles, where there's muscle atrophy at the base of the thumb. Let's talk about the special tests. There are 2 special tests to remember for carpal tunnel syndrome: Phelan's test and Tinel's test. Phelan's test, spelt with a PH, involves fully flexing the wrist and holding it in this position. Often this is done by asking the patient to put the backs of their hands together in front of them with their wrists bent inwards at 90 degrees. The test is positive when this position triggers the sensory symptoms of carpal tunnel syndrome, with numbness and paresthesia in the median nerve distribution. Tinel's test involves tapping the wrist at the location where the median nerve travels through the carpal tunnel. This is in the middle at the point where the wrist meets the hand. The test is positive when this position triggers the sensory symptoms of carpal tunnel, with numbness and paresthesia in the median nerve distribution. A tom tip for you: to remember which way round Tinel's and Phelan's is, I remember tapping a tin can for Tinel's test. Next, let's talk about the Carpal Tunnel Questionnaire. The Kamath and Stothard Carpal Tunnel Questionnaire gives a score based on the symptoms of carpal tunnel. It can be used to predict the likelihood of a diagnosis of carpal tunnel syndrome. A high score on the questionnaire may replace the need for nerve conduction studies to confirm the diagnosis. The score is based on questions such as: do the symptoms wake you at night? Do you have special movements, for example, shaking the hand, to improve symptoms? And is your little finger affected? Answering yes to whether the little finger is affected scores negatively, making carpal tunnel syndrome less likely. Next, let's talk about nerve conduction studies. Nerve conduction studies are the primary investigation for establishing the diagnosis. A small electrical current is applied by an electrode or nerve stimulator to the median nerve on one side of the carpal tunnel. Recording electrodes over the median nerve on the other side of the carpal tunnel record the electrical current that reaches them, and this demonstrates how well the signals are passing through the carpal tunnel along the median nerve. Finally, let's talk about management. Management options for carpal tunnel syndrome are rest and altered activity, wrist splints that maintain a neutral position of the wrist worn at night time, typically for a minimum of 4 weeks, steroid injections, and surgery. Carpal tunnel syndrome surgery is usually performed as a day case procedure under a local anaesthetic. It can be performed by open surgery with a vertical incision at the wrist, or by endoscopic or keyhole surgery. The flexor retinaculum, which is also known as the transverse carpal ligament, is cut to release the pressure on the median nerve.